I have clients who are in a lot of pain from traditional dentistry, and I have to guide them.
Oh, it's terrible. Yeah, traditional dentistry causes a lot of problems. It solves some, but it also creates some. So we have a kind of dentistry that solves the problems and then they don't come back. So that's the big breakthrough.
You're one of the founders of Biomimetic
Yeah.
Dentistry. Is that accurate?
Yep,
That's good.
that's
That's
accurate.
accurate. That's accurate. Wow.
You
Okay.
can ask Chat GPT, they'll tell you.
Wow. That's crazy. Okay. Well, hi, welcome to the show. I'm Malka Reichman, and we're honored today to have Dr. David Alleman on the show. Dr. Alleman is someone I've learned a lot from, and I'm really excited to be able to have this opportunity to be able to sit down and have a chat with you.
Right. So glad to be here on your program and tell me a little bit about your podcast. How long have you been going?
So we're kind of new and we're trying to teach people on how they could kind of take responsibility for their own health. In the Western world, people think that they need to have their doctor. That's the one who manages their health. And what people need to realize is that it's my podcast called DIY Health, where you're the one who takes responsibility for your own health. Right? It's not like a car that needs a mechanic. Like you need to know how to take responsibility. So dentistry is a major part of this because for some reason, like even people who are so informed about taking care of their health on a daily basis, like they eat right, they stay away from the wrong foods. But then when it comes to dentists, they think that dentists, whatever the dentist says, that's what they're supposed to do. And they really don't know what it means to take care of their own health when it comes to teeth. So first, I'm not sure. Do you agree with Dr. Weston Price's work that cavities self-heal and a demineralization diet causes tooth decay, or you're still
They
with the regular
often,
dentist?
yes,
Yeah.
yes. So I'm very, very, very familiar with his work. And so I grew up in Southern California, and that was basically his place where he had most influence. But the mineralization, demineralization, that's a part that we call minimally invasive dentistry. And that's still an active part of science. We have at the Alleman Center uh, four different mentors that teach. And one of our mentors is Dafina Dobrodoli. She's just finishing a PhD in Croatia. And she's also finishing a master's degree at University of Indiana right now. But her specialty is that remineralization, healing of lesions. But that's a small end.
Hmm.
What biomedics is kind of like we call it two ends of an enchilada. I don't know if you know
Hmm.
Mexican food, but
Hmm.
Mexican food, you take one bite, but then if you eat the whole thing, you're going to be really full. But minimally invasive dentistry, remineralization, having the tooth heal, that is a very important part of it. There's six stages of decay, and it's called an international caries assessment and risk assessment. And in that area, the six different levels of decay, levels one and two are really amenable to minimally invasive dentistry. Level three and four are not, but you still use preventive measures to make sure that the same problem doesn't reoccur. But the problem where minimally invasive dentistry and what we call normal dentistry, traditional dentistry that has some success in these levels three and four of decay. The levels five and six where fillings fail. So once a
Oh,
filling fails, the dentist says, okay, you need to have a crown. Or once a crown fails and says, the dentist says, you need to have a root canal.
this is because
Or,
so much of the tooth was already removed, right, from the previous dentist?
and,
Oh.
and the main problem is that people, dentists included, don't have a scale in their head about what they need to do to keep bacteria out of the tooth underneath the restoration. So, traditional mechanical dentistry, where you're holding on a crown by cutting down a tooth, or you're making a hole certain shape so that you can hold the filling. This is called mechanically retained dentistry. It was invented over 100 years ago. The founder was named G.V. Black, who systematized the mechanical approach. It did pretty good on these middle-sized lesions. It didn't do anything for these small remineralization situations that we can do with minimally invasive dentistry, and it didn't do well with these large cavities where there's not much tooth structure left. But for these middle ones, a lot of our parents were benefited by having some fillings that lasted a while. But then, um, as the fillings move and the tooth moves, you have what are called micro movements. And so let's say this is the side of the tooth, this is the side of the filling. When the tooth moves and flexes, there's no connection. And so you have a film of bacteria about 100 to 200 microns in this gap. Same thing with the crown. When the crown moves, the tooth underneath is not connected to the crown. So the tooth is actually what's called hypofunctional. It's not supporting the top. So the top moves, but the tooth doesn't. And so this gap that's underneath the crowns is about 200 microns again. And that allows bacteria to replicate. Fermentable carbohydrates are the main substance that the bacteria use in their replication. And so, as those grow over the years, usually at about year 3 or 4, you have a pretty substantial biofilm. And then in years 5 or 6 of a crown, for example, you'll get active decay recurring under the crown. And the problem underneath crowns is you can't see what's going on. You can't assess how much decay is there until it becomes so um, in place that it starts to affect the inner part of the tooth, which we call the pulp. So once the bacteria get into the pulp, then this inflammatory reaction that causes actually the death of the pulp. This is where a lot of pain comes, and most traditional dentistry, if you have a failing crown, then you'll just say, well, we have a solution for that. We'll just take out the pulp. So that started about 60 years ago. That's called root canal treatment. And root canal treatment, once the pulp is out, then the pain organ of the tooth, which is that pulp, is gone. So it doesn't hurt, and patients like that. But again, if the inside of the tooth, which now has been removed, doesn't have a seal on top, again, you can have the bacteria go into the under the crown, down the root canal treatment, and reinfect the tooth, and the tooth can reabscess. And then there's different ways to retreat it. But all of those cycles of a filling to a crown to a root canal to a retreat of a root canal, those are all time consuming, expensive, uncomfortable, even painful treatments. All of those can be stopped if you're able to treat the lesion in these early stages 1 and 2. But the real benefit of a new way to do dentistry is those lesions from 3, 4, 5, and 6, large or failed restorations. Now we have a way to seal them in a way that they stay sealed and they can't be infected by bacteria, because the seal that we can make is much smaller than a bacteria. A bacteria, if you look at your fingernail, that's about 500 microns. It's a half a millimeter. And a bacteria is usually about 1 to 3 microns. So very, very small. But the seal that we can make with these chemical um, adhesive treatments is on the nanometer level. So it's like a fifth the size of a bacteria. So we're actually now connecting the material to the tooth. So when the tooth moves, the filling moves. When the filling is chewed upon, the tooth moves, just like a natural tooth. A natural tooth, all of the stresses of chewing are distributed through the whole tooth. And so that's why we call it biomimetic. It mimics biology, mimics life. So this biomimetic dentistry is now reconnecting the tooth the way a natural tooth is. It's connected side to side, front to back, and top to bottom at a strength of about what's measurements is 30 megapascals. That's a physical engineering term. But basically, it's very strongly connected with these new techniques. And now these restorations, we have many that are approaching 25 years. So I
Wow.
I
Wow.
invented this system 25 years ago,
Oh,
there's
wow.
other contributors in the science from Japan and from Europe, some United States also. But the main science that was there's three universities that really contributed the most: Tokyo Medical and Dental University in Tokyo, and Amsterdam Dental School. It's called ACTA, ACTA, and then a school in the United States called Medical College of Georgia, which is a dental school. Now it's called the
Mhm.
Dental School of Georgia.
I thought
But
that biomedic dentistry, in addition to just trying, you're saying it's a lot of it is trying to do these micro seal level, but I
oh,
thought it's
yeah, that's
minimally invasive. Like they don't sit there with a big drill and break most of the tooth to create a crown, or they're not supposed to break into
correct.
a small filling, right? Because you
Yeah,
believe that instead, yeah.
all of those destructive techniques led to what's called a mechanical retention. And so when you're cutting a tooth for a crown or cutting a tooth for a filling, it's to make a form in the tooth that holds the filling, but it doesn't seal.
Oh,
So
I see.
the major paradigm shift started actually in 1980. That's a long time ago. But I was a dentist for 2 years in 1980. I've been a dentist for 44 years, so I've seen
Wow.
every step of this evolution from what we call adhesive dentistry to advanced adhesive dentistry that we've named biomimetic dentistry. So the
Oh,
seal is the deal. It's a nice little
oh,
saying a
oh,
lot of doctors say. But to have this seal uh, be permanent, this is what I innovated and others have followed. But again, when you say something's going to be permanent, you have to, you know, outlive
right.
the person that.
Exactly. The person themselves has
We've
is not so
had many
permanent.
of these restorations be permanent in patients that have passed away. But
Wow.
basically, we have clinical data of about 1 million teeth that we have restored in our network. And of those million teeth, as long as the protocols are followed, then you have the ability to say, okay, this is what it looks like in 5 years, this is what it looks like in 10 years, this is what it looks like at 20 years. And if they all look the same, then that standardized protocol predicts that it's going to continue um, to perform in that way. There are many, many confounding variables in the human body. And one is the amount of stress or the amount of pressure you can uh, put onto a tooth. And some people have bigger muscles. These are what are called the muscles of mastication. You have the masseter muscle, and then you have a large muscle here called the temporalis muscle. And those muscles basically, some people can chew at about 50 pounds. Some people can chew at about 950 pounds.
Oh, wow.
I mean, in the human bell curve of being able to chew hard or soft. There's a variability,
Oh, really
but a lot
interesting.
of people have studied those things, and they basically it's more important in a mechanical approach. I won't get into too many of the details, but the the type of dentistry that can be done biomimedically works whether you're a hard, high force chewer or a low force chewer. But the
Oh,
only thing that's different is the top of the tooth. You might change a little bit of the materials, but basically in a tooth you have three levels. You have the level that's connected to the tooth, and then you
I see.
have intermediate level that replaces the part of the tooth which is called dentin, and then you have the top of the tooth which replaces the part of the tooth called enamel. And so there's a gradient of stiffer on top, more flexible, and the most flexible is right down there next to the pulp. And so we have this ability to mimic this increase in stiffness, and the top of the
Oh,
tooth in a patient that chews really hard. Sometimes the best material is actually gold.
really?
But as you go down into the tooth, then you want something that mimics the flexibility of the tooth. And the
Mm.
flexibility of the tooth, um, the materials that we have uh, are just, it's amazing. I mean, you see something that you did. In fact, I had a patient that came in last week. I'll be seeing her tomorrow. She's been out of the state for about 10 years. I haven't seen her for 10 years, but 20 almost 24 years ago, we fixed one tooth on her. And then
Wow.
last week, she actually, or 2 weeks ago, she came into the office. I was so glad to see her. I hadn't seen her for 10 years because I knew that she was living with her daughter. But now she's 87 years old. She wants a couple of her old crowns um, redone. We're going to see her tomorrow. But this one tooth that she came in, I said, "Oh, this is so great. We got this picture of this tooth's 24 years old.
Wow.
And you have a little bit of wear on the top with this composite material that we usually use. But the bottom of the tooth is the most important thing. The two
Wow.
crowns we're replacing on her, they always leak at the bottom.
Mm.
And then when I took the x-ray on this lower bicuspid, no leakage, no sensitivity, everything great. It's kind of like,
Wow. So you
and we
put
have,
different types of plastics on one tooth? You put
well, you do. It's basically three layers. So you have a
three
more flexible plastic, close to
mm,
the pulp, a little more
mm,
stiff, and then the top, you can either use plastic, ceramic, or gold. And so you
mm.
have this gradient of stiffness
Wow.
in
Can
that.
I ask you some questions
Sure. Yeah,
about your
ask
work?
questions. Go
Okay.
ahead.
Okay. So I hear different opinions from dentists about what they really could see on an X-ray. From you
Mhm.
doing this for so many years, what do you think? Could they really see decay, or it's just about could they see what's a real tooth and what's a filling?
Well, here's the problem. You do see decay too late because an X-ray only shows you 1/3 of the amount of decay that is present. And so a minimally invasive lesion, if we talked about this international standard of decay, the first two uh, lesions will not show up on decay. I
Hmm.
mean, on X-ray. You have to do what's called a drying technique. And the drying technique is very simple. You just take air and around the grooves on the top of the tooth where decay starts, if you don't see any radio opacity, but you dry it and you start to see a little bit of radio opacity, that's the beginning of the demineralization.
Hmm.
So the second stage is using not a sharp explorer, but a round explorer.
Hmm.
So if you dehydrate and you see a little bit explorer and you rub that area, and you can see it, but it's smooth. Level two decay, you can see it when you dehydrate it, but it starts to be rough with
Hmm.
this round tip explorer. And most dentists in dental school don't learn ICDAS. ICDAS 2 is the acronym for this system. But again, if you're a PhD student like one of our mentors, Dafina Doberdoli, this is what you do. I mean, there are experts in minimally invasive dentistry to try to prevent the ever having a need to take out decay. But once you get into that level three, then the decay is very, even without drying, you see the you
You
see
think
the
something visible on the tooth is already
it's
called level
visible on the
three?
tooth.
Oh.
But again, what the Explorer does is that it starts to poke and actually can create uh, just an aggravation of the plaque accumulation in these deep grooves. Once the plaque is into a deep groove and it's not a smooth surface, you can't brush it off.
Oh,
So
so
it
you're
will
saying,
continue. It will continue. And so you referred to Dr. Weston having some ideas about remineralization. They're all true.
mhm.
Unfortunately, once they get into these level three and four,
Oh.
you cannot remineralize down. Now,
Mm.
there is
Hmm.
one system that actually it was a breakthrough. It's been out for about, oh man, 20 years now. But again, most dentists don't have this system. It's called ICON. It's an infiltration system that can, through certain acid treatments and certain infiltration of certain small, very small molecules, take a lesion that is into dentin, just that half millimeter or a millimeter even into dentin, and they can seal that and then the bacteria inside go to sleep. They don't replicate, they can't get food source. But this ICDS treatment actually takes as much time as drilling, filling, all that kind of thing, but it is better. And
Hmm.
so
So what could you
most
actually see on an X-ray? Just want people to
you
realize
would see
what,
you would see a
yeah.
little bit of a dark area that's called a radiolucent area.
Hmm.
So enamel looks white on an
Hmm.
X-ray.
Hmm.
Dentin looks less white,
Hmm.
but a lesion will actually start to look black, a
Oh,
carious lesion. So you have enamel, then a little bit of black, that's the carious lesion, then the dentin will be less white, but it won't be black. And so you can
hmm.
see that, and that can be documented. And
Hmm.
that's a conscientious dentist will always document those. And
Hmm.
you
But
can
there's
see
there's a shadow though, no, from where
there's a
the
shadow.
angle. So
Yeah, it
how do
looks a
you?
little.
But there's a shadow from there's one angle they're taking the X-ray from, like from outside
Mhm.
in instead of inside out. So how do they know the difference
Correct.
between
Yeah,
a
there are
shadow?
there are three-dimensional cat. Um,
But in a 2D scan, could they see the difference between a shadow and a cavity?
they can, but it's something that you need to have um, a little bit of knowledge about this level 1 through 6 progression, and
Hmm.
but it's something that a patient can see if a dentist takes the time to show that.
Hmm.
But the shadow that's in the enamel, that is usually what's called uh, a watch. And so a dentist usually will say, this is something that is really related to your diet. Do you drink a lot of soda pop? Do you drink a lot of particularly a soda pop out here in Utah that's popular called Mountain Dew? My son loves it. I love it. But you have to brush and floss your teeth because bacteria love the amount of sugar that's in soda pop. Okay. So, a lot of health conscious people don't drink soda pop like my wife. We're 74 years old. She'll live to be
Wow.
100. I'll probably live to be 98. No, I don't know. But the traditional dentists all learn in dental school that in a practice, that's usually the person that monitors the oral hygiene of the patient. All of that is very important for biomimetic dentistry, minimally invasive dentistry, and traditional dentistry. But the problem with traditional dentistry, once you put a filling in
Yeah.
or you put a crown on, then the x-ray cannot go through that
Oh.
filling. It cannot go through that
Oh.
crown. So all of a
Wow.
sudden,
You can't
a
even see
virgin
with an
tooth
X-ray.
gives
Wow.
us some ideas with an x-ray. A
Very
filling or
interesting.
crown does not give us information with an x-ray until
Yeah.
it's largely decayed and then it's underneath and you can see it. But by that time, the pulp is usually infected and on its way to dying. So dentists will say, well, you have to have a root canal treatment because you have this recurring decay or this deep decay. The
How do you
advantage
know a
of
tooth is dead? What's your
the
definition
test is
of
the cold test. So you
oh,
take ice or
uh,
material. It's called endo ice that you
oh,
spray onto the tip of a cotton pellet and put it on the tooth. If you feel it cold, there's some vital tissue in the inside the
oh,
tooth. Usually, you will test several teeth to see
oh,
the response.
oh,
Some teeth have an ambiguous
oh,
cold test. It has to be monitored. But the
oh,
real thing that you want to avoid when a patient comes in, for example, into our office and they have a filling that has deep decay around it, or a
hmm.
crown that now has decay around it, we ask the patient, have they ever had spontaneous pain? So, spontaneous pain means you're just lying in your bed or reading a book, something you're not eating. And if the tooth just starts hurting and lasts for like a half hour, you take some pain medication. It may or may not take away the pain. But if you have spontaneous pain, that means the infection is causing necrosis inside the tooth or death of the cells inside the tooth. So that does require a root canal treatment before you do a
You do root
biomimetic.
canals even though even though you're familiar with Western Price's work and how
Sure.
dangerous they
Yeah.
could
So the
be.
whole idea
Yeah.
of root canal failures is not the root canal treatment, but is actually leakage underneath
Mm.
what you do after you do the root canal. And so once you have the root canal in place, if you restore the tooth with a seal that seals out bacteria, then the body heals, goes back to normal, and everything is fine. But Weston Price didn't have any
Yeah,
way to seal the
he's
tooth.
saying it's really dangerous because you have a dead tooth trapped in the head. How do you avoid, how could that be
Correct.
any
Yeah.
different even with your seal? Like you're, at the end of the day, if it's
So
dead material.
the dead true tooth trapped in the head has a healing mechanism that can be turned on and is turned on once a nerve dies, and that's called a an abscess. An abscess is millions of white blood cells. White blood cells have one job: detect bacteria, kill bacteria, and then make antibodies against that particular bacteria. So, white blood cell accumulation at the bottom of the tooth, once the bacteria are gone and stay gone, then the healing at the bottom of the tooth that detected the dead nerve, it starts to say, okay, we don't have to worry, there's no more bacteria coming in. So all those white blood cells, little by little, go away into the system. And then you have a recreation of the bone at the bottom of the tooth. So
But it's
Weston
so
Price did.
controversial. Yeah, this root canal.
It's not
Uh,
controversial among people that
yeah.
understand it, but
Uh,
it's still Weston Price is, he was a pioneer, but like all pioneers, you find a way, but you don't understand everything that is going on. And
mhm.
you know,
You're saying
if
you see you do that you just to know what biomedic dentists do and they don't do. You're saying you still do root canals. You still,
correct,
if you feel like, I'm just curious what your philosophy is. You're saying you still do root canals. You just only do it if the decay is up to a certain point. You try to avoid them or whatever because you don't want to bring
correct,
so
yeah.
much to the
So
tooth.
if the decay is going, it's progressing. Let's say here's the pulp, here's the enamel. The progression is a very linear progression. And so it might take several years to get to the area where it's going to the pulp. But the bacteria that are going into the pulp, they get in to the pulp early on. It's just the more it progresses, the more bacteria that are in the pulp. And the pulp has the ability, just like your skin,
Hmm.
underneath your skin, if you cut your skin and you introduce bacteria into what's called the connective tissue, which has the blood vessels, which allows communication with the injury with your immune system. The immune system has a great way to keep you alive, but it does require these white blood cells to have the
Right, but
ability.
if the nerves were taken out and it's dead, it's like, it's just dead.
But that's
So,
inside. So it won't
yeah.
heal inside if you allow the infection to become too great. And so
Uh-huh.
the inside of the tooth is called pulp. If it inflames, then that's called pulpitis. And
Hmm.
so a pulpitis that's reversible means that the bacteria are being handled by the white blood cells inside the pulp. If it's irreversible, that means that the immune response is what's called cascading, and these cascades of chemicals that come into the pulp from the body is quite sophisticated. I mean,
So you're
it's
saying that you still think, even though you know what Dr. Esther Price and work, you still advocate for root canals because you feel like
absolutely. So
you could create a seal.
If Weston
You
Price was still alive, he
you
would
feel
be
like
a
because you could
biomimetic
seal. What's the
dentist.
difference between you do and what Dr. Weston Price was doing?
Weston Price never had adhesive dentistry, so Weston Price is dead. You know that, right?
Yeah, yeah, yeah.
Okay, all right.
Right. Yeah.
So when he died, there was no ability to seal. Adhesive dentistry really doesn't come to the United States until the 80s.
Uh,
And so even people who were following Western Price in the 80s never understood the potential of adhesive dentistry because there are some very important scientific concepts in adhesive dentistry that if you don't master them, you will have the same
right. I think his concern
failure.
was more like the aspect of dead, tooth in the mouth rather than things going into the tooth. Okay, let me ask you.
Mhm.
Some people have a bridge, like a traditional dental
Yeah.
bridge, and that could cause
Mhm.
so much pain
Problems.
because
Yeah.
they're in chronic pain because their face muscles can't are not flexible enough, and they just have odd pain. So what
Mhm.
I recommend to people is to take this bridge out and rebuild the teeth that were broken down. What do you recommend as a
That's what we do. Yeah,
dentist? That's what
that's
you
what
do?
we do. We don't really promote
Mm,
traditional bridges,
yeah.
but there are times where you can, before you do a bridge, seal a tooth and then do a bridge on top of the seal. But the bridges and the function, they are three times as prone to failures as single crowns. A
Wow.
bridge has two crowns, and then they have a space here. So these two crowns, the movements that they have are
Yeah.
much more non-biomimetic than a single
Yeah.
crown. We talked about a single crown moving, the tooth not moving. In a
Wow.
bridge, you actually have several vectors of movement, especially a bridge that goes around a corner, like right
Wow.
where a
Wow.
cuspid is.
But you could rebuild if someone wanted to take off a
Yeah.
fixed bridge, you try to rebuild the two teeth that were
What we
decimated.
do, what we recommend
Uh,
is a bridge on the back is much different than a bridge on the front.
hmm
So a bridge on the front, we can use materials where we're just bonding the bridge and we have flexibility in the materials, and those have long-term successes. They do need to be replaced about 10, 15 years. But on the back, these same materials are subjected to forces that are 10 times. In
Wow.
other words, when you bite on your back teeth, these muscles are the ones that really bite down. If you bite
Wow.
something on the front, it's good for cutting things, what's called incising, but you don't chew on the front, okay?
Wow.
And so the forces are very small on the front. So bridges, adhesive bridge on the front are very predictable, last more than 10 years for sure. Bridges on the back, they will fail about three times as fast. And so we don't do adhesive bridges on the back. The mechanically retained bridges sometimes will last 5 years, sometimes 10, but they have to be replaced. So the technology that has improved the most in the last 40 years for replacing teeth is called implants, and
Right.
implant technology
They're
has the
very,
ability.
I know, but they're also, they could cause problems with the
Oh
bone
yeah, they if like
and their
if you
rejection.
if you're not an expert in implants, then you're going to have implant failures. You spent your money and you still don't have a tooth
It's
in
crazy.
5 years.
But
That's not good.
how would you rebuild after a crown, the decimated teeth? I'm curious to hear the
Yeah,
ability of
so
biomimetic
this is
dentistry.
it's actually very difficult, and it still is not as
Wow.
predictable if we have tooth structure to work with. So in a
Oh,
tooth,
yeah.
basically we what we teach is that there's essential tooth structure and there's non-essential, meaning that the non-essential tooth structure can be replaced several times without any problem. But the
Oh,
essential tooth structure is where the level of the pulp is and lower.
oh,
So you
oh,
have about on the top about 5 millimeters of tooth structure that can be replaced predictably.
oh,
Below, and most teeth are about 10 millimeters high, about the
oh.
size of the end of your finger. So if you have a
Wow.
tooth and half of the tooth you can
Oh,
replace easily, but the bottom part you have.
oh,
Once
wow.
you do a crown, you've removed so much of the bottom
Wow.
part of the tooth that's close to the pulp.
Wow.
Very difficult to have a tooth move and flex like a natural tooth. But what you do is you seal it and then you put a crown on it and you tell the patient the seal will last, but the crown will probably still need to be replaced. In fact, I just
Uh-huh.
replaced one of these this week, or what are we? Last week, my brother came up from Arizona and we did a crown 20 years ago using that technique where we sealed it. We took off his old gold crown, we sealed the tooth, and then we put on a composite crown. It lasted for 20 years and then it started breaking
Wow.
down. But when it broke down, there was no reinfection underneath. So I just had to
Wow.
make a new crown.
Oh,
He's
wow.
80,
Oh,
81
wow.
years old, so this will be a permanent restoration for him. But the
Wow.
traditional progression from crowns to root canals can be stopped by
Wow.
using biomimetic techniques for that
Uh-huh. Wow.
remaining tooth structure underneath the crown.
But you could rebuild, let's see, because they break so much of the tooth to create a bridge. And if someone wants to get rid of this bridge, you could rebuild after the breakage.
You would rebuild the tooth, and then you'd
Yeah.
recommend to put an implant in the missing area.
But
That
the
would be our,
sides,
our approach.
Oh, that's your approach, yeah. But the sides could be rebuilt by a biomedic dentist?
The sides can be rebuilt by a
Wow.
bionic dentist. Yeah, that's I've done that many, many times. And I was
Wow.
a traditional dentist for 17 years, so I
Wow.
had every failure many times. I knew
Wow.
exactly. I was so frustrated with traditional dentistry that I actually quit dentistry for 6 months. So
Wow,
that's a
it's a
long time
wild
ago.
story. No,
It
it's an
is.
amazing story. You know, big
That's right.
comeback, a huge comeback. Let me ask you, so could you explain to people how would you rebuild a tooth that was broken down
Yeah,
to
so
fit for a bridge?
the first thing you do is you have to mimic what's called the DEJ. So in a tooth, you have the outside, very different material, enamel, from the inside. The inside is flexible and moist, the outside is dry and hard. But there's a connection there between the enamel. It's called an interphase, and this interphase has enamel and dentin. And then when it moves, sometimes there's a little fracture of the enamel rods, but there's always this flexibility of the dentin. So that interphase keeps teeth connected to the enamel to the dentin. So we mimic that when we are putting a restorative material to the tooth. And the connection is about 200 microns to 500 microns, which is about the thickness of your fingernail is 500 microns. So that connection of the restorative material to the tooth is constructed with what's called a dental bonding system. And that dental bonding system has the ability to take away a little bit of the minerals of the dentin and infiltrate with molecules that become polymerized, that become like a plastic into the tooth. And it has that mimicking of this DEJ, the dental enamel junction, but on a closer to the pulp situation where you have a harder material, a softer material, and you have to have this connection, which is called the hybrid layer.
Mm-hmm.
Now, this concept of the hybrid layer was first talked about in 1982, was got a name, and the person that named it was this person right here, Nobuo Nakabashi. Now, Nobuo Nakabashi, obviously, people that want to do healthy dentistry won't know that, but you should, because the science and scientists become very important. And the scientist that helped Nakabashi is named Dave Pashley. And so Nakabashi was at this Japanese university, Tokyo Medical and Dental University. Dave Pashley was at Medical College, Georgia, United States. But when they wrote this book and published it in 1998, when I was first,
So
mm,
you sorry, just to understand, you rebuild you rebuild the tooth after there was something that was broken down to a bridge
yeah.
by what? Layering plastic? What do you do?
Well, you
Like
have
it's a lot
that's
of
this
stuff that have
idea.
to be
This is a
rebuilt.
this is a new word to you, but this hybridization, this is called the hybrid zone. So this connection of the tooth to the material
So what does it
is a
mean? A
very
type of
complex.
plastic?
It's a very yeah, it's well, most people think of plastics, maybe they would drink a soda pop out of a plastic bottle. The molecules of any plastic start off very small and then they polymerize. They become stiffer as they start connecting. So these polymerization reactions, you have to become an expert in them. My major in college before I went to dental school is microbiology, so I know a lot about bugs, about bacteria versus virus, etc. But this polymerization is a specialty of what's called organic chemistry. That was my minor at the university. And so you have to have a very firm foundation in chemistry and microbiology to understand this interaction. But this connection of the plastic to the tooth has to be smaller than the size of a bacteria. And
Hmm.
so to do that and to keep that without any gaps forming, that's the techniques that I developed that have to be in place, and it has a time component, which is very important. If you fill a tooth too fast with these plastic materials, you will always have gaps around the filling that allow sensitivity and bacteria to reinfect. So
Hmm.
most dentists think I'm going to do it faster, I'm going to make more money, but these fast techniques they act just like the traditional amalgam fillings, or sometimes even worse, because
Wow.
the gaps around the composite can be
Really?
very large. Yeah.
Really? You
So
talk about
white
regular
filling,
composites
yeah, white filling can be worse than an amalgam filling. That's,
in
you
terms
know,
of
we don't
gaps. Wow.
we don't want you to use amalgam. It is a toxic material, but it also doesn't bond to the tooth. But these
Right.
bonding materials, if a dentist is not taking seriously the chemistry of these
Wow.
materials, production of the materials,
Wow.
there's maybe 50 manufacturers of these materials. The ones in the United States that we use, you know, the kit can cost $400. You'll get many treatments, maybe $10 per tooth that would cost the dentist. But in China, you can get a material that's supposed to be similar and it can cost you $4.
Wow. My question though is, do you do blood serum testing?
Yeah, there's some tests that
Do you do
they've
this?
used
Because
over
there's
the
so many
years.
different composites and people have real reactions to
Right. And
composites.
so those types of tests were very popular by a doctor named Hal Huggins, who was, a
Right.
disciple of Weston Price. Dr. Huggins was doing the right thing for the wrong reason, but he didn't have the right techniques. And so
Hmm.
systemic
Hmm.
ailments that may or may not be related to a certain type of material. That's a whole different
Oh.
discussion. But Dr.
So,
Huggins kind of got in trouble with that, and he didn't have a way to really seal a tooth. So he could say, "Don't do this," but he didn't have a positive way to say, "Do this."
uh-huh.
If it,
But you
if
don't
it
generally test for by, do you
I
do
don't,
blood?
but we have doctors whose patients want that because they have
Oh.
that idea, and there
Oh.
are biocompatibility tests that have been done, but they've been done mainly on non-human primates, and that
Oh.
testing is a very special testing. A good friend of mine, Charlie Cox, did it for 40 years. He passed away to 2022, so that's 3 years ago. One of his students in Japan, I still know him. I saw him last year, but to have monkeys do dentistry on monkeys, it's not an easy thing to do. They don't
Right.
cooperate very much. But these non-human primate tests to test the biocompatibility show biocompatibility for these materials. But I mean, it's a
So,
big story. But
don't they
if you
test it
have
on a person's own blood to see the immune response?
those types of coagulation tests and things like that have less validity because a body can take microplastics and you won't die from them. There might be an encapsulation, there might be something that you would excrete that would be the best thing. But that whole idea of
So you don't do that. You
having
don't.
we don't, but we do have dentists in our network that do that. But it's mainly under
It's not
the
your thing.
influence of basically under the influence of patients who have heard about Weston
Oh,
Price, or they've heard about Hal Huggins, they've heard about a
right.
biologic approach. And a patient who's worried about that, obviously, a dentist who takes that seriously, you don't want to diss
Right.
somebody who has a concern about something. But,
Right.
I mean, microplastics are in this soda pop that
Right.
I'm drinking.
Okay. Let me ask you. Um, do you have, as a biomedic dentist, do you have different dentures, removable appliances that you would recommend over standard ones? Or you
Nah,
mostly deal with bonding?
we don't.
Uh,
Yeah, we
so you don't know of anything different. Because also some removable appliances have mercury in the pink part or whatever. But
Mercury in the pink part isn't very common. I wouldn't
uh,
think it would.
oh,
It's possible. I'm not an
uh,
expert in acrylics, but acrylics are not metal based. So
mm,
some of the
mm,
metal that's in some of the dentures, you could
mm,
look at those, but the availability
mm,
of molecules of
mm,
particular metals in the chrome parts of
mm,
a denture, that could be something that could be investigated. People could worry about it, but haven't
mm,
seen any real clinical trials relating that to
mm.
long-term problems.
Very interesting. So from your experience on seeing failed tr failed dental
Treatments.
treatments. Yeah. What would you say is like your top five what traditional dentists do? What are like the top five to fail? Or like what are
Yeah,
you mostly
so
dealing with? Yeah.
right, the main problem is decay detection. In other words, if a dentist is taking out decay, how do they know how much de decay to remove? So the technology that your dentist should be using is called caries detecting dye. So that's a dye that was developed in Japan in the late 70s. It's been on the market ever since. I wrote with Dr. Pascal Magne from Southern California the definitive paper on how to use caries detecting dyes. So you could type in my name or Pascal Magne, Alleman, Alleman. And Magne is Magne. When we wrote this paper in 2012, it gave everyone a way to use caries detecting dye in a very scientific, systematic way, and using it with measurements as your guide to not take out too much decay. If you take out too much decay, you are going to hit the pulp, and that reintroduces more bacteria into the pulp. So if a dentist exposes the pulp, that's called a direct pulp cap, it will be very deleterious, 3 times as much chance of having the pulp die if that direct pulp cap is done. So we wrote the paper that said how to avoid direct pulp caps, how to avoid
Mhm.
pulp exposure. If you have a dentist that's familiar with Alleman Magne, caries removal techniques using caries detecting dye, they are in the top 10% of the dentists in the world, maybe the top 1%. I don't know. It's
Mhm.
been access. It's available online. You can read it. So it's 12 pages. And once a dentist reads that, it should change their life forever. But it slows them down a little bit because they're using this dye to be able to see where the decay is and then
Mhm.
evaluate where to take out the dye, stained decay, and where to leave it because complete caries removal is
So what
not
type of
about.
restorations do you find you're constantly fixing from traditional dentistry?
Oh, they're all,
Like what?
composite fillings, white fillings, amalgam
Oh,
fillings, crowns, all kinds. I mean, very
wow.
few gold crowns are being done now, but actually a gold crown saves potentially 20% of tooth structure. And the more tooth structure you take away, the more flexible it is. So actually thin gold crowns, if you have to have a full crown for a bridge for something, that's better. But these other techniques are more
Wow.
conservative. So
So you're
yeah,
saying you
less
replace
less
even
drilling, the better.
well, less drilling better, 100%. So you're saying you even replace composite.
Oh, all the time
Oh,
because
wow.
composites have the
So you're saying it's
same,
leaking.
have even bigger problems than amalgam. If it's not the material, it's
Wow.
how the material is connected to the tooth.
Wow.
If
It's
you
just not
don't connect
sticking.
the material to the tooth with biomimetic techniques,
Wow.
which kind of the phrase is called decoupling with time. We have to allow the bond to the tooth mature without stress of polymerization for a certain amount of time. It's usually five to 30 minutes, but those are all part of the techniques of how to do
Wow.
composite technique. And a biomimetic approach will usually take about 30% longer than a traditional technique. Sometimes it'll take 50% longer of a technique that a dentist is using to try to speed up placement of the filling. Taking out the decay, that usually will take a certain amount of time. Using the caries detecting dye will usually slow that down about 30%. But then
Wow.
filling the cavity after it's excavated, if you take too little time, then the polymerization stresses are so high that you will lose 80% of your bond strength, and then that will limit the longevity of the tooth. It could be failing in a year or two rather than 20 or 30 years.
Wow. Wow. So how do you offer any lessons for the layman?
Oh, well, for the layman, yeah,
Yeah.
you could go to my podcast, and it's called Six Lessons
Mm-hmm.
Podcast. and then you
Oh,
can listen to that. There'll be
oh
a
wow.
lot of technical stuff. It's for um, dentists. So we train dentists around the world. We have about, oh, probably 1,000 dentists that we've trained, and
Wow.
other teachers have trained other thousands of dentists. So there's probably 2 or 3 or 4,000 dentists out of the
Wow.
2 million dentists in the world,
Wow.
who are doing biomimetic. But the big thing right now is
Mm.
Instagram. We've been on Instagram for 5, 6 years.
Wow.
So you can look up my Instagram account. My son, who teaches with me, we're both named David Alleman. And so you should be able to put in David Alleman on Instagram and come up with our Instagram pages, and that can give you some ideas. But for the marketing to laymen and dentists, non-dentists, we haven't felt a real compelling need to do that right now, because if people who aren't dentists start going to dentists, say, "Are you a biomedic dentist?" Then the dentist will say, "Oh yeah, of course."
Oh, I
It's
see.
like
No, but they'll if they take your
there
course,
has
they'll know how to judge for themselves whether someone's a biomedic dentist.
well, they right now we have a brand, so
Ah,
this is a logo, this is a
uh,
brand. Other biomedic
uh,
teachers have different logo, different brand, but they will
I
use
see.
the word biomedic. And kind of the
Oh,
way to tell if a dentist has been trained by one of the leaders in biomedic dentists, he just says, if a tooth doesn't have a crown, do you put crowns on teeth? That's a simple question, but as soon as the dentist says yes, then you go to another dentist who says he's biomimetic and go there. So if you're
you're sa-
trained to a certain level of biomimetic
you're
competence,
saying I
you will
just want to be
stop.
clear what you're
You
saying
will
that you're saying
stop doing crowns. If a
you'll
tooth
stop
doesn't
doing
have a
crowns.
crown, a
You will never do
biomedic
a
dentist
crown.
will not put a crown on
Will
a
not put
tooth.
a crown. That's the test. Ah, very
That's
good.
the test. That's good. Good. All right. Well,
That's
I got to
excellent. Thank
run,
you. Thank you
but
very much. This is
it's been a lot of fun
fascinating.
talking, Maka. Till next time.
Okay, take
All right.
care.
Bye bye.
Bye.